we'd like to get started. In terms of upcoming grand rounds, next Friday, we have Dean Alpern, who's going to give his probably final State of the Medical School address. And then on the 8th of February, we'll have B.J. Casey, who's a professor of psychology here at Yale, who's going to be talking about the emergence of the adult brain, insights from cognitive and clinical neuroscience. Many of you probably know that B.J. is one of the leaders of something called the ABCD study, which is the largest nationwide study using brain imaging to track brain development in children and adolescents, and it's a longitudinal study and a really wonderful initiative, and I suspect that BJ will be talking about some of that work then. On the 15th of February, which is 3 weeks from now, Linda Carpenter returns. Linda was a faculty member here, resident faculty member here for a long time, and then moved to Brown, and she's going to be talking about TMS. So this is the winter, a stimulating winter. Last week we had Holly Lisenby, who talked about magnetic seizure therapy and ECT. I think that's about all the news we can handle right now. I just wanted to say how thrilled I am that Nolan Williams is here today, and I'm going to have Jerry come up and introduce him. So thanks.
So yeah, this is definitely three out of four on brain stimulation. I think Nolan's talk will be interesting because I think what it's really going to do is sort of be a bigger picture of how brain stimulation can play a role in at least advancing the role of neuroscience in psychiatry and neurology. So Nolan, I like Nolan because he doesn't move around much, so it makes it very easy to give an introduction. So Nolan started as an undergraduate at College of Charleston, and then moved about 3 miles away to MUSC, Medical University of South Carolina, where he did medical school, then stayed for residency, a dual residency in neurology and psychiatry, and then stayed around, did a fellowship in interventional psychiatry. And then in 2015, about 4 years ago, moved to Stanford, where it really has advanced the brain stimulation program at Stanford, really addressing some of the bigger questions in terms of the mechanisms of action of brain stimulation modalities. I think we're going to hear a little bit about DBS. We're going to hear a little bit about TMS and some new developments within TMS, a thing called theta bursts, which may actually dramatically shorten the duration of time in terms of how many ongoing treatments over a period of time people may need to get the true clinical benefit from TMS. But I think he's also going to try to get somewhat at the neuroscience of, tell us a little bit of what we're learning from this. So I really don't want to delay things any more than that and introduce Nolan. Thanks.
Thank you for the kind introduction. Let's see if I can there we go. All right, so Nolan Williams. So I'm going to be trying to give a broad overview with adding in specific details around a few projects that we've been working on. Disclosures. The goal of this talk is to introduce this kind of concept of interventional psychiatry, although introducing it to this crowd, you guys are already introduced at a level, have a great center that I'm aware of. Talk about parallels on how this field of medicine is developing relative to other interventional kind of subspecialties within areas like cardiology, neurology, radiology, and then talk about a general framework that we've been working on as far as further development of brain stimulation methods. So, as many of you know, this is early days of what some people are calling Psychiatry 3.0, the third pillar of psychiatry. I've heard these sorts of terms, but the general idea being that we're going after these problems at the level of the circuit, and we're intervening focally at that level of the circuit to move the system and to get people better. And so all neuropsychiatric conditions are conditions of distributed neural networks being dysfunctional. The ones that we have a little bit better of a handle on are things like Parkinson's, where we have a known pathophysiology, whereas in psychiatric conditions, we think that these are kind of circuitopathies or abnormal signaling within these networks. So, written a little bit about this with my friend Joe Taylor there. How do you think about a problem in psychiatry or neurology? I think you can think about it in terms of what we call nested hierarchies, or this idea of thinking within a level, or kind of a way to zoom into the problem. And so in this case, we're going to approach OCD at the level of the circuit. And this is a gentleman who had severe contamination fears, severe OCD in the operating room. And he's getting deep brain stimulation electrodes placed. But before we place the electrode, we have a microelectrode recording device that we've introduced into both the dorsal and the ventral part of the accumbens. And because he was obsessing about contamination of his toothbrush, we exposed him to both a sterile toothbrush and a contaminated toothbrush. And just to skip to the point, this is the contaminated toothbrush in the dorsal part of the accumbens. And what you'll notice, and maybe hear a little bit, is that after he exposes himself to that toothbrush, that area starts to really fire once we told him to imagine how contaminated the toothbrush was. And this actually reflects the sort of thing that we see with a Parkinson's surgery. So we were able to do the same sort of thing, but in the case of Parkinson's, activate the contralateral arm, because we're in a motor region of the subthalamic nucleus. But here we're in the accumbens, which was thought to be silent. We're able to induce an obsession and get that same sort of physiologic readout. The importance of this is, if you had an ongoing recording electrode in that was able to record and stimulate, one could track the physiology behind symptoms and be able to respond to those. So that's the general idea there. So spent a lot of my time studying treatment-resistant depression. The reason to do that is because it's the most disabling condition worldwide, as many of you know. Interestingly, it's now the fourth risk factor for development of coronary artery disease, along with hypertension, hyperlipidemia, and diabetes, which is kind of brings a new point in psychiatry. I think that we have the potential of intervening on psychiatric conditions that may reduce the chances of developing medical conditions, right? And then that's an important place to be, I think, if you're thinking in those terms. Another reason is that we have the brain stimulation a little more well worked out there. Certainly TMS and ECT there than other psychiatric or neurological conditions. So we know that depression is a disorder of aberrant functional connectivity. People that are depressed have increased functional connectivity between the subgenual cingulate and the default mode network. And the amount of abnormal connectivity goes up at the level of treatment resistance. The way that we, as you all know, the way that we deal with treatment-resistant depression is through algorithms, right? STAR-D, and kind of STAR-D bleeding into things like brain stimulation. And the real issue these days is that we don't actually have a treatment informing what to do for the next treatment, right? And so if you ask Group A, maybe you guys, what do you do after somebody's failed a certain number of meds? You may go to ketamine, other groups that are more on the ECT side, maybe go to, say, ECT, maybe TMS, but there's not really there's not really a sense of what the next step is, and I know there's work here and other places trying to figure that out. So the history of ECT, as many of you know, started prior to convulsive therapy with Hans Berger, which developed the EEG, which is fundamental in how we do modern ECT. Meduna developed convulsive therapy using chemical-induced seizures, and then a couple of years later, Cerletti developed the first ECT device due to the limitations of the chemical-induced seizures. Interestingly, Meduna had to leave Hungary because the psychiatrist at the time thought this was such a radical idea to give people seizures and try to improve their schizophrenia and depression. In 1941, ECT and EEG were combined to help you determine how long a seizure needed to be, whether or not the person had a seizure. And it's interesting, this is a biomarker, not necessarily of efficacy per se, but a biomarker of the treatment actually doing what we think it's supposed to do. ECT was grandfathered into the FDA in the 70s, and folks even in the mid-70s were thinking in terms of how can we speed up ECT, how can we get it, treat people faster, how can we get them better sooner. The problem with this move is that if you do multiple ECT sessions in a day, or even if you do ECT sessions every day instead of every other day like we normally do, people have profound cognitive problems, which limits kind of the schedule around ECT. Right, unilateral ultra-brief pulse ECT was developed by Sackheim in the early mid-2000s, and there's been a push by my mentor Mark George and Harold and others trying to develop things like a FEAST, which is like a focal type of ECT. Magnetic seizure therapy is another one. You guys heard about that last week. The ECT, the real trouble is that once you get into increasing levels of treatment resistance, you lose the ability to achieve remissions. Right? So there was a recent meta-analysis, and surprisingly, 48% of people that have treatment-resistant depression achieve remission with ECT. Whereas if you look at something like psychotic depression, it's extraordinarily high. It's in the 90%. So treatment-resistant depressed individuals getting ECT, but half of them get better. The suicidality goes down to about 2/3 of folks. The relapse rate is quite high as well, and why continuation and maintenance protocols were developed. And about 1/4 of folks will actually relapse in a week if you don't have continuation and maintenance set up. And the average length of wellness in somebody with TRD without doing continuation and maintenance is around 8 weeks. ECT is a great tool. It's helped a lot of folks. The trouble with ECT is that the amount of hospitals using ECT in the United States are very few, right? And that hasn't changed over time. And so only about 10% of US hospitals have ECT, and only about 1.5% of folks who meet Medicaid criteria to get ECT in the United States get ECT. And that's due to a variety of factors. 1/10 of hospitals have it, and then in that 10%, there's a lot of stigma and perceived real concern around cognitive side effects. But ECT reduces readmission rates, reduces post-hospitalization suicidality. And so we're in a real tricky position right now in psychiatry clinically, because we have a ongoing reduction in the number of days that somebody can come in for a hospital stay, and the suicide rates are going up. And so how do we get in and do something in psychiatric hospitals that's going to make a lasting change after their discharge and reduce risk? I would love for it to be increasing ECT. I think the reality is it's probably not going to be the answer. Coupled with that, the highest incidence completed suicide risk is in the months following the first hospitalization for a mood disorder. So there are a lot of things that go on after somebody's discharged for that, and And if the treatment wasn't optimally effective, then they're left with this risk. So if ECT is the best treatment we have and it doesn't work for everyone, what do you do? I like this paper. It came out right when I got to Stanford. And so it's two groups. So it's Lisa Mantasia at UT Southwestern and Carl Dijsselroth and Rob Malinka at Stanford. And Lisa proposed that you take an effective drug in humans, kind of backwards translate it into a mouse, you figure out what it's doing, and then you develop a new drug. And there have been a number of drugs that have gone down this road. Carl and Rob's suggestion is, let's understand the neuroscience, let's translate those findings into a human therapy, and then let's develop that therapy from there. We've done some work in ketamine. I'm not going to get into that. I'd be happy to answer questions after. And really the focus of this talk is around the second option, the second possible solution to having your best therapy for treatment-resistant depression only effective half the time, right? And so to me, that's finding something in neuroscience that one could scale out to humans and really pushing the envelope to build a new therapy that would work for this problem. And so there's been a number of attempts at this. TMS is one of those, and I'll go into that in a second. So just to kind of segue to the next step, I've thought a lot about how to build a new therapy. How do you build a new neuroscience-informed therapy that can improve efficacy rates in this very hard-to-treat population? What models do you use? And so cardiology has a model. It's an interesting one. So after the advent of using CT surgery to treat tetralogy of Fallot and other congenital heart problems in children, they found that they still had arrhythmias. And so the answer to that by Zoll and others was to develop a transcutaneous pacemaker, so an externalized device that could pace the heart and keep the heart rhythm out of these dangerous arrhythmias that could kill the child. And the good thing about this was that it seemed to work. The bad thing about this is that this is an externalized device that's pacing the heart, and if the kid comes off of this transcutaneous pacemaker, they go on to have an arrhythmia. And at the conception, I don't think that they were thinking we're going to build an implanted pacemaker. In my view, they were thinking, let's build something with the technology that we have to normalize the system so that we can study and understand that system, right? And so once they got going and they got it to work, then the push was how do we miniaturize this system to be implanted and to be able to do what it's doing transcutaneously all the time. And a number of innovations around implanted pacemakers came along around 10 years later. And so you can see this young boy and this gentleman here, they have a pacemaker, but the leads are externalized to a device. And if you're familiar with the history of early deep brain stimulation for Parkinson's, it looked just about the same, except the wire was tunneled up into the brain, right? So this idea of a completely externalized device and this kind of intermediate device that's partially implanted, partially externalized, to finally an implanted pacemaker that is completely implanted into the individual and under the skin. Okay. So there are a lot of interesting discussions around, this is better for this or that. I've tried to really conceptualize all of the upcoming technologies for depression and other things as being part of our armamentarium, right? And probably having a place in the treatment and care of folks through the kind of lifespan of their illness. And so, if you think about ECTs being a kind of a neuroversion of sorts, we do cardiac ablations, you can think about lesion surgery, using drugs to kind of neurovert people, if you will, and using something like RTMS, which I'll talk about in a minute, implanted deep brain stimulation, is kind of pacemakers, if you will. And so this is the first published TMS picture. Looks a lot like that transcutaneous pacemaker, if you remember, right? So this was published in Lancet in 1985. And this is kind of the future of TMS, right? It's this idea that that you have a robotic arm that's connected to a neuronavigation system that's basically a functional neurosurgeon's targeting methodology, and you can very accurately place a coil in exactly where you want the coil to be. And in the case of the motor system, actually have a readout of what we call the motor evoked potential. It'll tell you something about where the coil is relative to target, how intense the stimulation is relative to its kind of evoked activity. And so this idea of being able to take this kind of transcutaneous pacemaker of the brain and translate it into more target engagement focused specificity is really one of the ways I think we're going to get further in this field. And so you can see, just like my friends in functional neurosurgery registering the head to the neuronavigation system, you do this with TMS. You're able to get within a millimeter of accuracy, and you're able to put the coil, angle, tilt, pitch, all of these things in exactly the way that you would think it to be ideal and stimulate, even in people that are moving their head. You know, the robot will follow you. All right, so this idea of using neuroscience-informed stimulation to build a better type of brain stimulation for depression is rooted in a couple of insights in the mid-'80s. One of them is that if you record in a hippocampal slice, you get something that we call theta burst, or you get something that's theta frequency with bursts of gamma. And in 2005, that stimulation approach was applied in humans through motor cortex and showed that you could actually move cortical excitability in a pretty predictable way. And so TMS has a history timeline pretty similar to ECT. Tony Barker developed the first TMS device to go to brain in 85. 94, we started using TMS to move cortical excitability and using the motor system as a surrogate for this. In 95, Mark George did the first RTMS study in depression where he applied daily TMS once a day over several weeks to treat somebody at the NIH with depression. Theta burst, the stimulation approach I was just talking about, was first applied in 2005 in motor cortex. And then in 2008, we had FDA approval. The first accelerated TMS approach was done in 2008 by Paul Holtzheimer. And unlike ECT, there was no increased cognitive problems with multiple TMS sessions in a day. And in 2016, accelerated iTBS was first attempted. And just this past year, there was an FDA approval for this theta burst approach that I'll talk about in a second. And the importance of this is that theta burst, unlike the conventional TMS methods, is much more efficient. So you can give 3 minutes of intermittent theta burst, and it'll do the same thing to the cortical excitability that you can do in 40 minutes with traditional TMS. And so the idea of developing TMS parameters is that you can apply a stimulation technique to the brain, and you can actually get pre-post readouts of something called the motor evoked potential by recording EMG in the hand. And so if you do a single pulse of TMS over the hand region of the brain, you get an EMG readout with a certain amplitude. If you stimulate repetitively over time, if it's a biologically active stimulation approach, you can move that cortical excitability or that amplitude of the motor twitch in a direction. So when we talk about excitatory TMS, what we're really talking about is we're talking about TMS that increases the amplitude of the motor evoked potential or the excitability surrogate after you've run a session of that stimulation. If you do the opposite and you do inhibitory TMS, what you're doing is you're moving the amplitude of the motor evoked potential down. You're reducing the cortical excitability. And so that's kind of what's shown here. And so this is 1 hertz TMS. And the idea here, for instance, traditional 1 hertz TMS developed in the mid-90s, is that you can reduce cortical excitability. You make the brain less excitable. Whereas something like 10 hertz, you're making the brain more excitable. You're kind of turning that system on, if you will. And so that information, coupled with the early functional neuroimaging of depression, Mark decided we could use excitatory TMS, place it instead of over the motor cortex, over the prefrontal cortex, which was hypometabolic on PET, and excite that area. And that was really the aha moment for him, right? This idea of combining something that was basically a research tool in the motor system that wasn't being conceived of at that point as a therapy with early functional imaging data and then trying to move that functional imaging data. And TMS has been developed over time to where we've gotten slowly but increasingly more aggressive with it. And this was a recent, or not so recent, I guess, meta-analysis showing that just by increasing the number of days and increasing the intensity of the stim and increasing the pulses per day, you can increase the efficacy of TMS. And so TMS, as it was approved by the FDA, is a therapy that is applied for 40 minutes a day, and it's applied Monday through Friday, so 5 days a week for 6 weeks. This schedule is largely dictated by a number of technological factors that actually no longer exist. One is the coil used to heat up, and you'd have to cool it in an ice bath. And that process of, and people actually held the coil in their hand, that process of stimulating with the coil in your hand, dunking this thing in an ice bucket, the machine sometimes overheating, doing 3,000 pulses of standard TMS a day was like a big deal, even 15 years ago. The other thing is we didn't know what the cognitive safety was around this, right? We knew that ECT had some problems with autobiographical memory, and we didn't want to kind of repeat a similar sort of problem where if we did an aggressive TMS approach, then folks had some sort of deficit. And so in many ways, this was a very conservative approach. And if you think about it, if you put your deep brain stimulation hat on or your spinal cord stimulator hat on, we're giving those people about 500,000 to 2 million pulses per day with an implanted device versus 3,000 pulses of traditional TMS. So I actually, and I'll talk to you about this in a minute, but I actually think that pulse-for-pulse TMS is the most potent brain stimulation device that we have, pulse-for-pulse. And so, so people get about 90,000 pulses per course in that way over 6 weeks. The left DLPFC, or left dorsolateral prefrontal cortex, is targeted using skull-based measurement techniques, so ruler on head, which works. And there are ways that we've figured out to do this that will get you into the DLPFC most of the time, but the DLPFC does a lot of things, right? One of them appears to be having a role in mood regulation, but does a lot of other things, executive function sorts of things. And in that way, we get about 30% of people remit and 50% of people respond in an open label way after the 6 weeks. What's interesting is that 2 years ago, they took folks that were in the BrainSway trial and they just gave them another 6 weeks of TMS. They took everybody that was a non-responder, and 62% of those patients then became responders just by essentially doubling the dose. So this theta burst that I've been talking about, So like I said, theta burst was derived from hippocampal slice recordings. It's been applied to hippocampal slice, and I'll talk about that in a second. And it looks like it's able to enlarge dendritic spines there. And in humans, we're able to take that patterning and program that into a TMS device. And when we do, we can move that cortical excitability surrogate that I was talking about a minute ago. And in a recent study that was published in The Lancet, 600 pulses of intermittent theta burst, which is 3 minutes, was non-inferior to a 40-minute RTMS treatment. And if you think about it, if you're talking about non-specific effects, if you're talking about the kind of relationship with the treater and all of that stuff, trying to do a non-inferiority study with a much shorter treatment should kind of bias the study towards the traditional TMS actually winning because they're getting 40 minutes of interaction versus 3. And so, like I said, published in The Lancet, there was another study that was a blinded study that separated from sham with 1,800 pulses a day, and this will be important in a second. So kind of a triple treatment at the 2-week mark. So triple treatment for 2 weeks or single treatment for 6 weeks, both seem to be effective to treat depression. And another thing that I found when I was kind of trying to understand the properties of this sort of stimulation is that there's actually a time interval that you need to stimulate before you re-stimulate. And it's about 50 minutes, and we'll talk about that in a second. And so this is the graph from that Lancet paper, and this is basically superimposed lines, right? This is 400 patients, 200 in each arm, non-inferiority study, and 3 minutes of theta burst versus 40 minutes of traditional TMS. And so, there are a ton of, so what's the practical implication of this? Basically, every TMS facility in the United States is, as soon as FDA approved this, is transitioning to theta burst. So if you think about it one way, and I'll talk about it in a different way in a second, if you think about it one way, where you're my friend Jonathan Downer, who's in Toronto, who led this study, and you are in that kind of a health system, you're trying to treat as many people as you possibly can. So pragmatically, actually being able to treat people not every 3 minutes, but maybe every 6 minutes or something like that, you can get away with treating more people per chair, right? You can get more done. And that was really the reason, the rationale at the clinical level for doing this sort of non-inferiority study. And so again, what that says is that 3 minutes, Monday, Tuesday, Wednesday, Thursday, Friday for 6 weeks is non-inferior to 40 minutes of the same exact schedule. But it's still coming in once a day, every day for 4 to 6 weeks. That paper that I was talking about a second ago with 1,800 pulses of iTBS once a day, every day for 2 weeks. It's interesting. A lot of people talk about the recent VA study and other things. TMS, sham TMS is pretty good placebo, and that seems to be true when you're talking about people with low treatment resistance. And you can see this. The NeoSync trial, it was the same sort of overlapping curve. But as you go out and you get into higher levels of treatment resistance, you start to lose the sham TMS effect. Okay. So a couple of years before I got to Stanford, I read this paper that it was really curious to me, where they took individuals that had a right middle cerebral artery stroke. Anybody's ever seen somebody like this? They have something called dense hemineglect, visuospatial hemineglect. So they won't attend to their left visual field very well. And so the stimulation strategy there is to actually inhibit the unaffected hemisphere, to inhibit the left posterior parietal cortex. And if you do that with 1 Hertz TMS, you do it for 20 minutes, you get about 20 minutes where the person's actually able to attend to that side. If you do 40 seconds of continuous theta burst, so a much more efficient inhibitory form of theta burst, you get 40 minutes. If you do it and then you do it again, and you have an interval in between, you get 8 hours. If you do it 4 times, you get 32 hours. If you do that same stimulation approach the next day, you get 3 weeks. It's kind of non-linearity. This building, the first stim doing something additive to the next one. The intersession interval has been a big question for people in this very small kind of niche of trying to develop rapid-acting TMS approaches, because you really want it to be optimized for the kind of rules of LTP or LTD. And so human studies have informed this, that kind of thumb twitch surrogate that I told you about. If you do excitatory theta burst once, and then you do it again 15 minutes later, you don't get a change in cortical excitability. But at the 30-minute mark, you do, right? So you need it in humans at least 30 minutes. In animal studies, in hippocampal slice, if you do iTBS, and then you do it in an interval anything less than 50 minutes, you enlarge some dendritic spines, you prime others, but the prime spines don't enlarge on the second stimulation. However, if you stim and you enlarge some, prime some, and you wait 50 minutes or more, then you enlarge the prime ones and prime more spines. So this idea of using something like space learning theory to inform a TMS approach. Another thing that we've used as a readout is something called TMS evoke potentials. So this is a cortical excitability readout that's been validated in the motor system, but actually is using EEG. So if you do intermittent theta burst at 50% of the resting motor threshold, this is kind of baseline, 5 minutes, 30 minutes. You don't really have a change in the cortical excitability. And if you do 100%, you don't either, actually. But if you do 75%, you have a change. This was a study where they did 80%, you have a change. And so this idea of being able to kind of find this sweet spot of intensity seems to be important. And then we've additionally taken into account the differential prefrontal atrophy that occurs to deal with depth, and I'll talk about that in a second. So we developed this kind of hypothesis-driven treatment schedule that is the most aggressive TMS approach that I know of so far that's been published. And so if you remember, I told you they gave 600 pulses of iTBS a day, once a day, every day for 6 weeks in the Lancet paper. That's a total of 18,000 iTBS pulses, right? We give 18,000 iTBS pulses in a day. Or we're giving a 6-week course of TMS each day. Or we're giving 7.5 months worth of TMS in 5 days. So there was a fair amount of data that informed that this would be safe, and it is. That wasn't 100% clear at first. But the idea here is, going back to the original thing that I introduced you to, we have a problem with hospitalization, stays being short. We need to be able to treat somebody in less than 7 days, and we need to be able to do it in a broad scale across hospitals across the United States, right? And we need it to be durable out to the 1 month, the 3 month time period in order to really make a dent in this problem. And so the pragmatic kind of reason why I was doing this was that I thought that we could get TMS onto the inpatient unit. We could build a therapy for the inpatient unit, because psychiatry is the only specialty in medicine in which, as you increase the acuity, you decrease the options, right? So as you put somebody into the hospital, they lose certain options that they had outpatient, right? Everybody has the option of doing ECT outpatient, right? They also have the option of doing ketamine outpatient. They also have the option of doing our standard TMS outpatient. And in many circumstances, you go into a US hospital, none of those things are available, right? And so the idea of being able to build a TMS approach that could be put into an inpatient unit and scaled out widely was the pragmatic reason. The science reason to do this is that we've never done a dose response curve with TMS. We never kind of flattened the curve. We never plateaued the curve. And if you tell that to a pharmacologist, they're just struck by this, because the idea of, as you know, of all drugs is we want to get a sense of a dose response curve, and that just wasn't done because of a certain number of assumptions around the concern of having side effects similar to ECT. Okay. And so we used 18,000 pulses of iTBS a day because of that sham-controlled trial I told you about, or a session, I'm sorry. we used that prolonged iTBS session. We found it to be additive in non-motor physiology applications. We used the 50-minute intercession interval for the reasons I described earlier, space learning theory. We decided 90,000 pulses was what is applied in a traditional TMS course over 6 weeks. And so if we were getting worse response remission numbers than the open label TMS studies, then we've done something wrong. So it wasn't a pulse dose issue. And we knew that because iTBS has kind of got 5x potency, that we should be really giving 5 times the amount. And so with any stimulation approach, you're asking for cortical stim and for non-invasive stim, you're trying to hit a cortical kind of entry target or an area that you're going to kind of get into the network with. And you want to know if you're going to perturb the activity in a direction. DLPFC is really the most widely studied target for depression. There are others, but it's really got all of the sham-controlled trials behind it. We knew that DLPFC homologs in mice seem to be effective with optogenetics to produce reductions, say, in addiction models. And we know that from Mike Fox's work that there are these relationships between cortical targets for TMS and deep brain stimulation targets, where he actually took the human connectome database and he asked the question, if you put a seed in the TMS target, what's the most functionally connected area, whole brain, and ended up being the most widely used DBS target. And you do the same thing in the reverse, and you find the same thing in the reverse for a number of conditions. Mike also showed that the DLPFC, as far as its relationship with subgenual cingulate is concerned, has variable amounts of connectivity to the subgenual from DLPFC, where Brodmann 46 is really the most functionally connected. And we know that that makes sense because of Helen Mayberg's work as it being kind of a modality-independent treatment-responsive biomarker with some limitations. And recent work that he's done has shown that if you do TMS in the standard way and then you ask the question of proximity to the optimal target, there's a linear relationship, right? So the closer you are to that ideal target, the greater the antidepressant effect is there. And that's replicated in a letter that was published in Biological Psychiatry 3 days ago by Paul Fitzgerald's group. And they used personalized, they looked at the personalized functional connectivity target and it looked even better. We also know that the state of the network will actually tell you something about the stimulation, where if you pre-stimulation look at functional connectivity between motor and premotor, it informs you as to whether or not you're going to have a cortical excitability change. And the resting state will actually reflect changes from TMS. So TMS appears to be a frequency-dependent functional connectivity modulator that you can send that functional connectivity relationship in opposite directions based on excitation or inhibition. So present a little bit of our data with the caveat this is open label data, but in severe folks. And so we had baseline MRI, the 5 intensive days, another one, and then one at 30 days. I gave myself a lot of expectations in all of this. I needed it to perform as well as ECT and treatment-resistant depression in an open-label way. Wanted it to last as long as ECT, and be able to finish within the time course of a psychiatric hospitalization. So befriended a guy by the name of Keith Sudheimer, who's collaborator as a subgenual imager, and he developed, before we'd actually talked, developed a way of looking at the resting state using hierarchical clustering kind of machine learning algorithms to actually parse out specific areas within the DLPFC that are behaving similarly. And we did that in the DLPFC and in the subgenual. And then if you do that, and these are dendrograms, if you do that, you can actually use a 0.5 correlation coefficient and say, okay, anything that is better than that will clump together as a similarly behaving subregion within Brodmann 46, and do the same thing in the subgenual. And the reason to do that, if you can see, is that if you look at a time course of an ROI, Brabham 46, you get areas that are acting in kind of opposite phase with one another. And so trying to use the entire DLPFC as a target, you're probably getting some kind of complicating signals being sent, if that makes sense. So what we apply is this decision algorithm. So we say we want a bigger cluster because the TMS pulse is about 2 centimeters. We want it to be pretty cohesive. We want it to be anti-correlated with the subgenual cingulate, or as much as it can be. And so this automated algorithm will actually take a raw resting state scan in a T1, and in an hour spit out a nifty file that has our target with all these parameters fed out. And what we get is a superimposable functional target. And so here's some of the data. I've got kind of two types of tables. One of them is everybody. So we've treated a few people with depression who had comorbid Parkinson's, and some folks with bipolar disorder, bipolar 2 and 1. And so we have about 31 of those folks for the outpatient study. And then 22 of kind of clean TRD individuals within this larger sample. And they're pretty severe, you know. They're kind of 8-9 med failures. They've had a pretty chronic course. The Maudsley refractoriness scale, which is what we use, was an average of an 11. So an 11 to 15 is severe treatment resistance. If you remember that graph I showed you earlier, it was the one on the far right, which doesn't have, in blinded studies, doesn't have a placebo effect from TMS. It's about the same for that kind of subsample. And these are our response remission numbers. And I was not expecting this. You take this with a caveat that this is open label data, but the BDIs, so the self-reports and the clinician rated scales were in lockstep with one another. And the SI, even in people that were, a few people that were non-responsive, goes, and it actually goes first in the week. So that's the first thing to go away. And so this is the smaller sample. It's the same general numbers of kind of clean TRD folks. And really what we're doing, like I said earlier, is we're doing a dose response curve. These are the numbers that you get with deep brain stimulation in Parkinson's. But you give 500,000 pulses a day, every day. What's interesting is that you plateau the curve on the improvement of the motor symptoms in about 2 to 3 hours. So if you do the math on that, that's about 90, 100,000 pulses. All of a sudden you stabilize the effect. And so this idea that you can really push the system and get better responses, actually, a neurologist to me understands this because maybe we're just not stimulating enough. Maybe we're actually in the right place generally, but not in the best place in that area, which we know from deep brain stimulation to be important, and I'll talk about in a second. We just weren't giving enough. 3,000 pulses a day is kind of trivial in that way. And so we do ham-6s every day, and what you see is here are the numbers after the first day, right? If you were to look at the post, change numbers on the open label kind of standard RTMS, it's about the numbers. It's about the same thing. It's actually pretty predictable, it seems to us. And you just needed to keep going, it seems. So this is a lady who was given permission for us to show this video. I didn't know she was doing this until after she finished her week.
September 16th. For TMS.
Yeah, it's turned up as much as. Can you guys not hear that? Yeah, that's a good idea. Yeah. Let's open that one. Yeah, that works. Is that better? Sorry. Well, maybe you can just.
We get a sense of it.
Yeah, fair enough. Yeah, so this is her after. You probably can't hear her, but you can see.
Read her lips.
Yeah, this is like a test. I don't know. We'll skip it. You guys can believe it.
And you're regulating the
Oh, here we go.
stimulation of the brain?
Oop. Yeah. What was that?
No, I'm just
Yeah, there you go. Yeah, yeah. Yeah, that's right. Nice. So we took this out of the kind of clinical research area and put it into the hospital. We asked the question of, is this really, can you really move the dial in folks that are hospitalized, that have comorbid severe characterological issues, other kind of quote unquote axis 1 problems, and do something there. And so instead of using the targeting, we have to use the brain sway device just because of the limitations in getting imaging. These aren't people that are getting admitted to the hospital. These are people who showed up at the ER, were transferred with SI and depression, who we enrolled once they hit the floor. Very sick folks, actually. 3 previously had ACT, 8 had a suicide attempt. Previously, I think most of those a suicide attempt also when they came in. And we get similar sorts of numbers across that group as well. And this is, again, small numbers and the limitation of having no sham arm. We also asked the question of, for the targeting that we're developing, is this stable spatially? So this isn't particularly useful to get a target if the target's moving around a lot, right? And what we found is that it is within the diameter of the TMS pulse, the kind of variability within position. It's basically in the same place, scan over and over again. We're seeing changes in functional connectivity, correlating with changes in clinical scales across both the Hamilton and the Madras, with the DLPFC, the striatum, DLPFC, and the left centromedian amygdala. And the big question that everybody asks is, are you causing cognitive problems, right? You're stimulating this much, or are you causing somebody to have trouble with some of the domains that we see affected in ECT? And we don't see that. In fact, we see improvements in these various neurocognitive evaluations. And so we have a group that that stays pretty stable over time. So the average duration of response for the folks that we've treated that haven't failed ECT is around 15 weeks without doing anything else, no maintenance or anything. The people that have failed ECT kind of meet Helen Mayberg's criteria for deep brain stimulation implant, failed normal TMS, which isn't in her criteria, but we wanted that too. Many of them failed ketamine, many of them failed VNS. Those guys, it works, it dramatically works, but for this very limited time, for about 2 weeks. And so it feels like in that circumstance, this is a probe, not necessarily treatment itself, although we've given people, and you in the front end, you wouldn't imagine that somebody would want to do this, but talking to Jerry this morning, I think he could imagine this, right? I offered them 10 days, right? So 5 and then 5 more, and they were really excited about that idea. And then one gentleman, for instance, got 12 days, failed kind of everything under the sun. We did 2 weeks, he got 42 days. We did 2 weeks again, and then we followed it with standard TMS once a day. You get about 70 days. And so I think that what we're doing is we're simulating an implanted device environment. We're creating a temporary spinal cord stimulator. We're test stimming the system and trying to determine if we should put in an implant. And so, there's a lot of question about whether or not DBS works in psychiatry. Is this something that is applicable to psychiatric conditions? I would argue that we wouldn't be as far along in neurology with DBS if we didn't have this. This is 5 minutes later. Maybe some of you guys are movement disorder neurologists in here, but I would argue some of you guys, you don't need any training to see that, right? That is very apparent to everyone, to the family members, to everyone. And so because it's so apparent, it's kind of easy in a way. I anger them when I say that, but I think it's easy in a way, right? Because you are able to get a readout very quickly about whether or not you're in the right place or not. And we don't have that sort of thing available to us. In addition, a lot of the physiology that we do in movement disorder deep brain stimulation implant surgery to confirm placement isn't really there, especially in the subgenual singular. There's a white matter tract that has no fizz. There's no readout that you're in the right place, right? And so we have these failed trials. We have the VCVS, the ventral capsule ventral striatum trial, and DBS we have the subgenual trial failed, and there's a lot of, this may be one of the most controversial things going on right now in psychiatry about whether or not you think this is real or not, or what went wrong with this study or not. And I think that if you put on a different hat and you ask the question of methodologically, what do we do wrong? I think a lot of things were very limited with this trial, and the readout really isn't there. So the fact that it works for anybody is really actually quite remarkable. There was a study that's another kind of controversial study that was published out of Europe where they did something different. They did a temporary spinal cord stimulator kind of thing, if you will, but not so temporary. They implanted the lead into the reward circuitry, into the ventral anterior limb of the internal capsule, and then they open programmed for a year. And what they found was that when you open program, instead of in this case, you're kind of blind programming where you're changing things, but you don't really know what's going on because you don't know if the person's active or not. When you open program for a year and you find the best stimulation strategy for that person, then you do the RCT, then they had a pretty nice separation. So this is the responders, the non-responders during the sham program. Then this is the responders and non-responders determined during this open label phase during the active stim, and they found a separation. And I would argue that we're trying to do the same thing, but we're trying to do it non-invasively. The trouble with this study, if you're familiar with it, is they had 6 suicide attempts in the non-responders. And for all the vulnerabilities of somebody with severe treatment-resistant depression, and then they have to go through brain surgery, which is, if anybody's kind of counseled somebody through that, it's this whole thing of, is this really how bad it is? Why me? All of that stuff. If you can get them through all of that, and then they're still depressed, what's the first thing they say? I'm not even good enough to respond to brain surgery, right? I've heard that, right? That's kind of the statement that they make, and it's because they made this huge leap without really knowing if they were responsive. And maybe this works for everybody, and we just need to get the stim parameters better. Maybe this works for some people, and you have to do a brain surgery to know. And so we really kind of jumped the gun at a level, I think, with this, and we didn't do enough confirmatory steps to really get a sense of it. And I think that's what the problem with those early studies were. And so what I'm advocating for is this idea of using the non-invasive to screen invasive, to actually kind of retro-engineer a device that can do what TMS can do and put it in people that look like these guys, okay? My view of what we need to do. And this is just another graph of those guys. And this is somebody with Parkinson's depression. It was really actually hard to find these super failing people, so we included her, a different brain response. But everybody else, if you take her out, and the other folks, the 5 other folks, there was a reduction in the number of anticorrelations between DLPSC and subgenual in that group. And so if you look into the literature, there's actually a little bit of literature on implanting cortical stim devices, cortical paddles. My mentors did it back in Charleston. Another group at Harvard did it. And the signals look pretty good. This is data from the 5 folks that were implanted in Charleston. The trouble is that we're using really kind of low-tech stim parameters, right? We're using what the Medtronic device puts out. And so it took forever, right? And if you did once-a-day TMS, it's going to take 6 months too to get somebody like this better. And we've actually seen that. But if you did something that was more in line with the neuroscience, I think that you could actually move this dial. But with that, and again, with open label data and what it is, these folks had an effect and were able to maintain it out to the 5-year mark. And so the major kind of drive of what my lab is trying to do right now is just developed this methodology. We have a blinded trial going, an RCT to look at this in a controlled way, and then really ask the question after that of, can we really use this? And what's very cool about this idea, I think, is that there are certain things that you can learn about doing this non-invasively that you can't really learn doing it invasively. Like, you could treat everybody on the depression spectrum, and really you can actually compare people, because right now there's no treatment where you can take a treatment naive person and somebody who meets Helen Mayberg's DBS criteria and do the same thing and have it work, and study the biology and the differences between those guys. The thing about the invasive thing is the readouts that we use here, EEG or resting state, they're really limited. They have poor temporal or spatial resolution, depending upon the tool. And so something like an implanted device that can do the same data burst stimulation approach, and we're talking to companies to do this, that can actually read out ECOG in between, read out ECOG resting, read out at night. You got a movie now. You don't just have pictures. You have a whole movie about the resolution of the problem. And that can actually, I think, inform the TMS. I think there are some, maybe the folks that we don't have a durable response on, the few non-responders that we had, maybe those people needed differences in the STIM parameters that we're never going to be able to work out with a TMS study, that you could have something run an iterative kind of series of sequences and read out the ECOG on. And so I think there's ways to build this out to where this is kind of dually informing and really hit the whole spectrum of disease. And, you know, finally transition the last word of the Salpatria, and finally take this group of individuals and make their hospitalization look a lot more like what we do with epilepsy patients. This is the group. This is an earlier picture, this is more recent. And we, yeah, thank you guys so much for having me.